Good afternoon. Welcome to the Panamerican International Trauma Ground Rounds. This meeting is sponsored by the University of Miami and VCU. I would like to introduce you to Dr. Tracey King. Dr. Tracey King is a critical care fellow here at Rectal Trauma Center, Jackson Memorial Hospital, University of Miami. She's going to present 1 hour case that she had with Dr. Ratan. And please, Dr. King and Dr. Ratan, present the case and let's lead the discussions. Dr. King, welcome and thank you for presenting today.
Thank you, Dr. Martes. As Dr. Martes said, this is a patient that Dr. Ratan and I took care of, and I am a trauma fellow over at Jackson Memorial Hospital. This case is about a particular rectal injury with an associated soft tissue destruction. I have no disclosures. The scene is that it was a 30-year-old female who was a multiple gunshot wound with a shotgun to her sacrum and feet. There was a death that was on scene, and EMS had placed a right lower extremity tourniquet in the field. She was a GCS of 15, and her systolic blood pressure was 90s, and her heart rate was in the 120s. On initial primary survey, when she came to the resuscitation bay at Jackson, her airway was patent. She had bilateral breath sounds. Her systolic blood pressure was 112 and her heart rate was 112. The tourniquet on the right lower extremity was taken down at that time, and there was noticed to be brisk pooling around the foot, but nothing that appeared arterial. On her right foot, she had a 2+ dorsalis pedis pulse, and on the left foot, she had a 2+ posterior tibial pulse. She was a GCS of 15. She was very agitated and in severe pain. And on evaluation of the extremities, she had 3 apertures to the right foot. And on the left foot, there was a large soft tissue defect that had an exposed bony midfoot. On the secondary survey, she had a very large and obvious destructive sacral injury that was about 20 by 20 centimeters. You could just lift up her legs and then you would see this massive sacral injury. It was a high energy injury and had significant cavitation, and it was a full thickness destruction down to the extraperitoneal space, and this was above the anal sphincter complex. A digital rectal exam was performed that revealed gross blood, and there was also noted to be stool that was grossly contaminating the wound. What are the next steps?
Thank you, Dr. Kim. Dr. Antrach, Baghdad?
Yes, so there are still signs of first-degree shock with tachycardia, so significant blood loss, and so she needs 2 IVs and airway spine, 2 IVs, and perhaps in this case 2 units of blood as soon as it's available to see if she's a responder, if she stabilizes, and if she stabilizes, then she would, in this case, I would put dressings on the extremity wounds, which seem not to be actively bleeding and can be controlled with dressings, and she would need to go to the operating room for diversion, sigmoid colostomy, and then clean out of the rectal wound. It sounds like there might be too much tissue loss to do a primary repair of the rectum. So in this case, I think diversion is the most important step.
Thank you, Dr. Antrax. Dr. Amayas, would you like to comment?
Yeah, I mean, specifically on the rectum, if you've got all this soft tissue destruction down there, I think you want to divert this stream regardless. So we're going to divert the stream and just get hemostasis while you're figuring out what else is bleeding.
Thank you, Dr. Amayas. Dr. Frisby?
Yeah, that sounds about right. You did a digital rectal exam. Did you feel any defect when you had your finger in there?
Not with the finger.
I'm sorry?
No, not when you just put in a finger, just blood.
Okay. Yeah, I think that's exactly what I'd do, is just start your blood and take it down and debride this thing as much as you can and divert at this point.
Thank you, Dr. Frisbee. Dr. Kasim, Portland.
So can we step back and look at this a little bit historically? So the first person who advocated diversion was Dr. DeBakey, way back when he was in one of the wars. I don't know which war it was. So he was the first guy who said divert. Then came Vietnam. Then we got direct repair to this area. And then came the Middle East. Then we got distal lavage. So we initially started with 3D, and then we added a 4th D, which is distal lavage. And then there was a 5th D in the modern era. There are some surgeons who say, don't do anything, just resuscitate the patient and watch and see what happens. So obviously, there are many ways of treating this area. So I will give you my take on it for what I have done when I have seen something like this. But this is horrendous. This is not, this will separate the boys from the men. You have a big cavity in the back there. Things are exposed and leaking stool. Obviously, the first thing you would do would be you would resuscitate this patient and get the patient hemodynamically as stable as possible. And in the meantime, check the legs. There are several bullet wounds there. And ABI would give you maybe some idea where we are going with a leg wound. But the crux of this injury is the rectal injury, where the patient is leaking stool and has a big cavity. And what type of diversion you should do? In my opinion, the best diversion is going to be not a loop colostomy, as some surgeons recommend. I think I would like to do a double barrel or even a Hartmann. Hartmann is a little too extreme, maybe a double barrel colostomy, and then drainage of this area and wash out. And that is where I will stop for the time being. Get the patient stabilized and get him back to the intensive care to get him all warmed up, and then see what you're going to do next afterwards. Oh, maybe you want to do some type of an angiogram to see what the vessels are like, but that will be down the road as well. Thank you.
Thank you, Dr. Kasim. Dr. Ochman, Boston.
So just, this was a shotgun, wasn't it? No, not a regular, is this correct?
Correct, yes.
Okay, well, I would do the ABCs like we all probably do. And a shotgun wound to the pelvis, the things that you need to be concerned is genitourinary, the iliac vessels, and the rectum. So this patient, I would be concerned, I don't know if there is any evidence of bleeding or not, but kind of like a pelvic injury that might be bleeding. Without seeing the injury itself, it's difficult to assess, but probably this patient needs to go to the operating room and we do a laparotomy, see what I have in terms of bleeding, and probably use the hybrid room in case that she might need embolization. After that, she needs to be diverted. No question about that. I will do a double barrel. I would not do a Hartmann's because I would like to have the rectum or the whatever remains of the sigmoid to be draining in both directions. And it's very difficult to wash that area. I need to see how much of the bone is involved, and probably I will have to prone the patient and do the other side after I do the first part of the surgery, but the main concern will be injury to other pelvic structures. A little bit of trivia, and I imagine many people will call me an idiot savant for this, but the cavitation happens when we talk about cavitation and gunshot wounds is for high velocity bullets. And that happens when the bullet travels at the speed that are close to the speed of the sound in the tissue. And when that happens, the tissue cannot absorb energy by moving apart, and that's when you have cavitation. The speed of the sound in tissue is approximately 4 a little bit over 4,000 beats per second. The fastest bullets from an assault weapon is between 3,000 and 3,600, and that creates the cavitation, which is the tissue rapidly expanding laterally at the passage of the bullet, and it will give problems, for example, in solid organs. This is a cavity. This is not cavitation. This is a cavity created by the massive destruction of the shotgun. Shotguns are very, very destructive in short distance, but they are not high-speed bullets. So shotguns at 50 meters have almost no penetration, but at short distance are the most destructive of all the type of gunshot wounds that you can get. So this is incredibly destructive. The tissue is very devitalized, and this is a very difficult injury to take care of, despite the fact that might have not penetrated too far into the tissue, because the bullets are not aerodynamic. The round pellets that are there, they are not aerodynamic, and they do not penetrate very deep in the tissue, but they, in the short distance, create a significant tissue destruction. And now you can make fun of me for being a nerd. Thank you.
Thank you, Dr. Antrach. Dr. Weinstein, Ryder, would you like to make a comment?
No, I don't really have much additional to add. I do agree, large bore IVs, blood, OR, and based off the presentation, I'm debating whether or not the angio table is better or if the patient should be placed in lithotomy.
Thank you, Dr. Weinstein. Anyone else has a comment before we move on to the presenter again? Dr. Kim?
Thank you.
Yeah, please, any other participant who want to express your opinion, please let us know, okay? The meeting is open to everybody. Thank you, Dr. King.
Mm-hmm. So the patient was actually intubated primarily just for pain control, and we performed the adjuncts to the primary survey. So this is the chest x-ray after she was intubated. You can see the ET tube and OG tube are in place, no really major injuries to the chest. We performed a pelvis x-ray / KUB, and you can see that there's a bullet fragment that's within the pelvis or abdomen with scattered foreign debris, but no other like pelvic fractures that you can ascertain from this image. These are her foot x-rays on the right side. You can see she does have some metatarsal fractures, as well as an injury posteriorly near the calcaneus. And on the left foot, this is the side that also had the associated massive soft tissue defect. And she has scattered foreign debris bodies all within the midfoot as well. She was stable enough to go to the CT scan, and a CT scan of the abdomen pelvis with runoff of her bilateral lower extremities was obtained. This image, this CT image is just of her abdomen and pelvis. So I will play that now. It goes a little fast, but as you go down, you can see that there's a coccygeal fracture, sacrum fracture, and likely a rectal injury. And I'll play it back kind of over here again and go through it hopefully a little bit slower. And you can see that there is this massive soft tissue destruction that's been associated with that as well. So the final injuries from the CT scan is that she had an acute comminuted fracture of the lower sacrum and coccyx, acute fractures of the left sacral ala, a suspected rectal injury. She had non-opacification of the left plantar vessels, but did have triple vessel runoff on both sides. She had comminuted fractures of the right second and third metatarsal bones and comminuted fractures of the left second and fifth metatarsal bones. After this, she was taken to the operating room. What would be your order of operation?
Dr. Kasim, Portland?
Can you just go back one slide backward?
Certainly.
And I missed all that.
There we go.
Okay. Okay. So you have significant injury to the rectal area. I think that take precedence over all the bony destructions. And as Professor said, diversion is key. And I agree with my colleague from Boston. Double barrel colostomy is what I would do. And if at all possible, I would do retrorectal drainage, and I would not try to do any direct repair of the rectal injury unless I can see it very clearly. And I might be tempted to put a couple of stitches in that area. I would not do any distal lavage at this moment. And then I would probably look at the vessels to see what the status of the vessels are, to see if I can get by without having to operate on the vessels or do a distal bypass, etc., because that is going to be time consuming. Then I would call my orthopedic colleagues and other bone doctors to see how they would like to manage the metatarsal bones, and they may have the right answers for that. Comminuted fracture of the lower sacrum and coccyx also could be managed by the orthopedic surgeons. And that's the order that I would go by for this. Thank you.
Thank you, Dr. Kasim. Dr. Frisby?
Yeah, that sounds appropriate. I don't think you need to concern yourself in the beginning with any of the lower extremity issues. They don't appear to be that earth-shattering, pardon my French, but the rectal injury should take priority. And as we've discussed, double barrel diverting colostomy would be where I'd go. Just see if I could debride most of this non-viable tissue, see what I have left. That's about where I'd start.
Thank you, Dr. Frisby. Dr. Ochman, Boston?
Yeah, I don't have too much to add. I will go laparotomy. The foot will be the last. Probably ortho will be washing the foot while I'm doing something in the abdomen. I will do it again in the hybrid room. If I have any bleeding, I can put vessel loops around the iliac vessels and get IR to do an angiogram and embolize whatever needs to be embolized. And after that, I would probably flip the patient around and debride the backside, because you probably have a lot of fragments of bone that are devitalized, and the combination of a stool with foreign body and the devitalized bone is usually not a good one, but not too much to add here. Thank you.
Thank you, Dr. Ochman. Dr. Antrach, Baghdad?
Yes, I pretty much agree with all the other comments. I'm sure everyone initially, having seen the wounds, and we haven't seen what they look like, would have given her antibiotics to cover for the open fractures in the stool and the Peri-Sacral wound and tetanus immunization. And it says that the non-opacification of the distal left plantar vessels, so I assume the proximal left plantar vessels were visualized. So that's it doesn't look like there's any need for any vascular reconstruction, and especially not so far distally. I would consult the orthopedist early on and let them handle the open fractures of the of both feet and decide if they want to do it at the same time or at the end of the laparotomy. But I would get them involved, let them take care of that, and then primarily be concerned in the pelvis. After the colostomy, I didn't see on the CT scan the injury in the rectum. I saw a couple of slices with what looked like intact rectum with stool, but you know, at some point you need to examine the wound from posteriorly, debride it, wash it out, and you know, normally you need to at least leave a drain for a rectal injury. If the injury is open into the wound, then you know, I guess it would just be treated with dressings or wound vac, or but it would be kept open to allow adequate drainage after the debridement, and then the issues of the hemostasis, like Dr. Heumann mentioned.
Thank you, Dr. Antach. Ryder, Dr. Weinstein?
We're good.
Perfect. Dr. Mahoney, do you have any comments?
Oh, I agree with everything that's been said. Been listening. I agree with the X-clap. It looks like this is a buckshot rather than birdshot, which is more 9mm caliber in those. So that just what that X-ray showed. I'd like to make sure that this injury is all extraperitoneal and not intraperitoneal. There's no associated injuries. As far as preference, there's sounds like deliberation versus angio versus lithotomy versus proning. If it's actively bleeding, probably lithotomy. I would not do anything definitive other than clean this out and stop the bleeding. This is going to be a multi, specialist looking at this. I wouldn't do anything the first day because the next day we want to see what's actually still viable and what can we put together and what needs to be debrided. So it may just be control the bleeding and fecal contamination of the pelvis and kind of, regroup 12 hours later and try to see what we can do to start putting this together. But I agree with all the first steps: X-lap, diversion, clean out, wash out, source control. Thank you.
Thank you, Doctor. Anyone else has a comment? Dr. Kim, go back to you.
So we went to the operating room. She was initially placed supine in lithotomy. First thing that we did was an exam under anesthesia. First, we did actually like a pelvic exam and found that the vagina and everything else was completely intact. On the rectal exam, attempted a proctoscopy. There was noted to be 2 defects in the posterior rectum above the sphincter complex. A laparotomy was then performed next, and there was noted to be a zone 3 non-expanding hematoma that was left alone, and a loop sigmoidostomy was performed. We next washed out the left and right foot and controlled the hemorrhage from those sides. We couldn't get adequate visualization of the wound from the lithotomy position, so the patient was then proned, was re-prepped and draped, and washed out the sacral wound. Again, it was a massive 20 by 20 centimeter soft tissue injury that had spared the anus. There was a destructive posterior rectal wall injuries and appeared extraperitoneal, and there was significant contamination of the pre-sacral space. You were able to pass an entire hand through the ischiorectal space up to the sacral promontory, and was also having profuse bleeding from that area. The middle rectal artery was ligated. There was more control of hemorrhage, and we performed pre-sacral packing of that space. What else, if anything, would you do after this operation?
Boston, Dr. Achman?
Probably not too much more. The question is how to approach this from behind, put in a prone position, jackknife, or doing in a lateral decubitus. Probably will prefer this to do this in a lateral decubitus, but really not too much more that I can add at this stage. Probably many things will happen afterwards. How to, or if should be the rectal injury be fixed, or if this approachable or not. But no, nothing else. Thank you.
Thank you, Dr. Frisbee, Atlanta.
Just some consideration for IR. If you feel comfortable and the patient's still stable, I might consider asking IR to squirt a little dye in there, see if we've missed any of the vessels that are going to give us trouble later. But that's my only comment.
Thank you, Dr. Frisbee. Baghdad and Dr. Antrach.
Yeah, so from what you said, it sounds like there's a lot of tissue loss in the posterior mid-rectum. So really, I wouldn't do anything more at this stage. Later on, once the wound is healed, the pelvic wound is healed, it sounds like she'd be a good candidate for a colo-anal anastomosis or a low rectal anastomosis, but nothing that you could really do at this point. So I wouldn't do anything more than what you've done.
Thank you, Dr. Antrach. Dr. Kasim, Portland.
Well, what I wouldn't have done would be a loop colostomy, because when you have a significant rectal injury, you don't want any part of the stool traversing that area, and loop colostomy is notorious for that. And I think research have shown in injuries as severe as you have, double barrel colostomy works much better. So having said that, what would I do? Actually, you've done very well so far, but I think as you know, and I know as well, most of the bleeding is coming from the venous plexus under the sphere, and that's where the bleeding is occurring. But once in a while, you get a surprise. You have one arterial vessel that is bleeding, and for that reason, I would agree with my Professor Frisbee that I would send the patient for IRR just in case there is something that I am missing, and to see if they can identify if there is any arterial bleed that could be either embolized or coiled, whatever it is. I think that's what I would do. Thank you.
Thank you, Dr. Kasim. Anyone else? Any comments that would like to add? Dr. Kim, we go back to you.
So for the management of our other injuries postoperatively, we had an orthopedics consult for the sacrum and coccyx fracture, which was non-operative, and she was just non-weight bearing of her bilateral lower extremities. Podiatry was consulted for her feet, and at that time they were discussing either BKA versus a limb salvage. Vascular surgery was also consulted, but they were able to find PT and plantar vessels on the left side with Doppler signals. And they were able to palpate the DP and Doppler the PT. So there was no vascular intervention for the feet that were required at that time. Post-op day 1, she went back to the operating room with trauma and had removal of the lap sponges from the peri-sacral space. There was debridement and posterior of the posterior wall of the rectum and primary closure. And that was primarily just to control the fecal contamination of the wound. Podiatry at that time also placed, they repaired the left wound and placed an X-fix, and then also placed a mini X-fix on the right lower extremity. And then post-op day 3, the sacral packs were again removed in the operating room. She was debrided and a wound vac was put in place. This is just an image of the left lower extremity before podiatry did the debridement. They reapproximated some portions of the plantar aspect and placed the X-fix on that side. Unfortunately, this is the first picture I have of this wound. This is actually about 2 weeks out post-injury. So this wound is actually much smaller than it was initially. But you can see as the undermining portion, that is the portion that goes all the way back to the rectum. So even despite the primary closure from the previous operation, there is concern for continued rectal defect. There's still intermittent stool dressings from the sacral wound. What would be our next steps?
Dr. Antrach, Baghdad?
Yes, right. So in general, for extraperitoneal rectal injuries is diversion and drainage. In this case, the open wound is, I guess, the drainage. And if there's continued leakage of stool in the operating room, I would, or even at the bedside, I would do a washout from below just to clean out the stool. The diversion, the loop colostomy, I know there's a lot of debate about this, but even over 30 years ago, that I reviewed some studies, the question came up, and a well-constructed loop colostomy tends to be very nicely diverting. If you give radionuclide orally and trace it down, it goes right into the colostomy bag and not over distally. So that really, it defunctionalizes the efferent limb. So I doubt that she's probably now stooling into the colostomy bag at this point, and I would not expect that that's the problem. If it were the problem, then you'd have to do a complete diversion, separate the two limbs, or maybe staple across the distal limb, the efferent limb. But I would doubt that would be the issue. So I would wash out the rectum, allow the wound to heal. If she's likely not to form a fistula, a rectal fistula, if there's good drainage from below, if there's a washout, and it's likely going to heal. There might be a stricture, but and eventually she might need a partial resection with a colorectal anastomosis. But I think at this point that the wound actually looks good, looks like it's healing.
Thank you, Dr. Antrach. Dr. Kasim, Portland.
I tend to disagree with my professor from Baghdad and Dr. Isidore Cohen, who was in Louisiana, and also a fellow called Nance. They did some very good studies on these, loop colostomy and the double barrel colostomy. And they convinced me, at least from their study, that in a significant injury to the rectum, I'm not talking about little gunshot wound to the rectum where there's a tiny little hole there that can sustain a loop colostomy, but significant injury to the rectum like you have here. Diverting colostomy by double barrel colostomy is the ideal way to treat with it, because after all, you know, if you are leaking stool, it must be coming from somewhere, and the only place you can come is from nose. And so I would go back, take the patient back, and do a double barrel colostomy, and then do all the things that you're supposed to do to the distal wound, and allow this is extraperitoneal, allow the things to heal. Hopefully it will heal, given all the support that you're going to be giving this patient, nutrition, antibiotics, vitamins, and all that sort of thing. And effective drainage is the key here as well. Thank you.
Thank you, Dr. Kasim. Boston, Dr. Ahmed.
Well, I have to say that Dr. Kasim called this from the very beginning. This patient needed a double barrel colostomy to have a complete diversion. A few things about the complete diversion. In order to do a loop colostomy, the rod that we put underneath, kind of like this, doing this, has to remain there for a long period of time. If the rod is removed in the first week, which is what many textbooks recommend, what Dr. Kasim is describing is going to happen. I have to say that I have been burned many times. I kind of like in trying to do a diverting loop colostomy or ileostomy. A few tricks to prevent this from happening is leaving the rod for a longer period of time. One trick that I learned from the chief of surgery when I did my residency in New York, which I never found it described in any book, but it really worked, particularly with ileostomy, is to do the brook, the ostomy in the distal end. So the stool that might be sitting, or the suckers that might be sitting into the back, has less chance to go in the distal end. But I have been burned many times thinking that this was going to work, and it didn't work. And in those cases, what I did, which is an easy solution, can be done essentially at the bedside, is staple the distal end with a TA stapler and divert it completely. I might do something like this later on in a patient like this, because by then there shouldn't be too much stool. I wouldn't do this in the acute setting because it might be too much stool. It might not go down through the rectum, and it might drain backwards through the double loop. But later on, that's maybe an option. But yes, definitely this patient needs a better diversion in order to allow that area to heal, because as Dr. Kasim said, if you see a stool there, it's coming from the ostomy. Most likely, the child might have an internal fistula, but I think that's very unlikely. Thank you.
Thank you, Dr. Ahmed. Dr. Frisbee, Atlanta.
Well, the only thing I have a comment on is it's rather ironic that part of the cure for this, or not the cure, but for the treatment, is a double barrel colostomy for a shotgun blast. That's just an observation, but I think Dr. Kasim and Dr. Hoytman have it right. You really need to get complete diversion here, and once you wash him out, he should, with enough drainage, he should close now. It should close. But that's all I have to offer.
Thank you, Dr. Frisbee. Anyone else? Any comments from the audience? Dr. Kim?
Thank you. So post-op day 16, after this observation, a colonoscopy was performed through the anus, and which really did just demonstrate that the primary rectal repair had dehisced. But we just continued doing wet to dry dressings to the destructive peri-sacral wound and it fit about like a Curlex of packing. Here's an image of that colonoscope. As you can see, it looking straight out into the world through the rectal wound. And the picture on the right shows the view from the colonoscope. I think we kind of beat this over, the head, so I'm going to move forward about what we did. So we, on post-op day 22, she ended up getting an IND of her left foot with wound vac placement and was placed on Zosyn for Pseudomonas and Enterococcus osteomyelitis, and eventually had removal of her left excfix and split thickness skin graft placement. Throughout her hospital course during this time, we really just continued the wet to dry dressings to the Peri-Sacral wound, and eventually ended up switching to just 4x4 wet to dries. So we had a really good progression of the closing of that wound. So this is a picture of her left foot after the excfix and wound vacuum for quite some time. And this is near the end of her hospital stay, where they had placed a split thickness skin graft over that site and the excfix was removed. The next couple of pictures is a series of the Peri-Sacral wound. So this was about 1 month out from her initial injury. This next wound is about 1 week later, and you can see it's closed pretty significantly. Again, another week later. And then, sorry for the poor quality of the picture, but this is almost about 1.5 months to 1.3 weeks of the wound after just doing wet to dry dressings. So then on post-op day 47, the right lower extremity excfix was removed. And then on post-op day 48, she was discharged home with home health and had 4 weeks of Zosyn for that left foot osteomyelitis. And we just continued those wet to dry dressings in that small little wound that she had left. So questions are, what are future concerns you have about rectal healing, any potential complications and management, and what would you want to see or do before reversal, or would you never reverse her?
Okay, Boston, Dr. Hochman.
Well, she's a young woman. I think we should do everything possible to reverse her. At this time, we usually handle all those injuries in-house, meaning by the trauma team. However, this is way out. And this is one of the cases where I would involve the colorectal surgeons, because I think this patient, we need to first to confirm that the defect has sealed, and this is not so difficult. You can do a barium enema or you can do another endoscopy, but most importantly, I think this patient would need a defecography. I wouldn't be surprised if she has some autonomic dysfunction for the extensive destruction of the sacrum. So even if reconstructed, the sphincter might not work well or might have problems in that sense. So at this time, I would probably get colorectal surgery involved. I will let them take the lead. And if it's possible, they should find a way to do a reconstruction, or meaning to close the colostomy. But I would not probably do it myself at this time. Thank you.
Thank you, Dr. Hochman. Dr. Frisby?
Yeah, I think those are major considerations. This rectal injury is probably going to scar down, and you're going to need somebody who is in that area daily to let you know just how to manage that narrowing of the rectum. And but I'm not in favor of taking that colostomy down until I get some answers about the things that were discussed, such as the sphincter tone, and whether there's going to be any atonia of it. Those are questions that are better answered by the colorectal surgeon. I think that's right. That's all I've got.
Thank you, Dr. Frisby. Dr. Kasim, Portland.
I think this will be years before I reverse this patient first. And in the meantime, I would definitely, as Dr. Hoffman says, get advice from the experts in this field, i.e. the colorectal surgeon, in particular, somebody who is really very good in looking at the functional mobility of the rectal area plus sphincter tone, how it functions. I think they have modern technology available where they do pressure measurement and electronic gradient measurements and how the sphincter works, etc. I think they do all the studying, either inpatient, outpatient basis, to make sure everything is functioning A-OK before you do a reversal of this. Otherwise, you will be back to square one. I think so far she has done very well. One other thing that I forgot to mention earlier on, that when you have stool like this, the enterococcus is one of the major problems that we have had at the hospital where I work. It has been a problem for us, but I should have thought about that. Again, the reversal is going to take months or years, and I would not rush into it. And like Dr. Hoffman says, that we will get a lot of help from the people who are very good at this, not the trauma surgeons. Colorectal surgeon is the one who can determine and then give you the final okay for you to reverse, or he can do it himself. Thank you.
Thank you, Dr. Kasim. Dr. Antrach, Baghdad. Thank you.
Yeah, so pretty much I agree with all the comments. The colorectal surgeons can do the anorectal manometry, but I would at this point I would probably want to see for myself. I would do a gastrographin study, or barium would probably be okay. If there's still a leak, it'll come out right through the wound. But a study through the distal limb of your colostomy, since you have that accessible, and then see if there's a fistula, not a fistula. And the question would be, if it eventually seals off, does the patient need a colorectal reconstruction? That would be the question for the colorectal surgeons. And I think there's a possibility that if everything heals okay, there's no leak, and the anorectal manometry is normal, then she might just eventually come to a colostomy closure, which you could do that just as well as the colorectal surgeons. But I would definitely involve them, and I'd be interested to see what the studies show now, the contrast study at this point.
Thank you, Dr. Antrach. Any other comments? Dr. Kim, we go back to you.
So this is pretty much the end of my case. That was so far what we've done for her, has gotten her to the point where she could go home. So if you guys have any further comments or questions.
Sure, final comments. Portland,
So
Dr.
maybe,
Kasim? Oh.
So maybe also we can invite Dr. Rishi Ratan to make his comments also about the case, and following Dr. Ratan, we can have the final round of comments. Dr. Ratan, welcome.
Thank you so much, and thanks everyone for sharing your comments and experience. I think the massively destructive extraperitoneal rectal injuries are obviously tough cases, and we had a lot of help throughout her course to get her to where she is today. But, I think what I found interesting about this case as I was taking care of her was that this really isn't so much in the textbooks. When we learn about extraperitoneal rectal injuries, at least as American civilian surgeons, a lot of these are not as destructive as this. And so I think there's, you have to go a little bit out of the, the cookbook when taking care of these injuries. And in retrospect, I think, I think we've discussed about the double barrel versus loop, but I will say my initial impression was that this was still stool in the distal segment that was slowly leaking out over the first week, and then it sort of cleared up on its own. But I think in retrospect, I probably would have been a little bit more aggressive and done a distal rectal washout, even though, in these like small penetrating wounds and things like that are low energy, it's not really necessarily recommended routinely. I think this one would have qualified. And then, I also appreciate the comments about IR. We did not involve IR on the first day. But I do appreciate everyone's comments about that. In retrospect, they probably could have been a little bit more involved, potentially. But yeah, it was a really interesting case. It was a sad case. You know, the trajectory never quite made sense. That's why I took her to CT scan first. She was a responder to resuscitation and had stabilized. The trajectories as we were looking at the x-rays and missiles did not make sense. So it does seem like it was sort of like a perineal shotgun blast that was aimed posteriorly. And so luckily, a lot of the anterior pelvic organs and structures were preserved. And I think she was quite lucky for that. But yeah, it was a tough case. And I think a lot of the times there was a feeling of having to, or wanting to do more, because we were staring at this gaping wound day after day. But I think it was a lesson learned of just sort of sitting tight, letting the body do its thing and heal, as long as you've diverted the fecal stream. And you know, she did most of the healing on her own. It wasn't really us. We were just doing wet to dries. But she so far has had a good outcome. But again, I thank you for everyone's comments.
Thank you, Dr. Rattan. Dr. Kasim, Portland, final comments, please.
I think I should congratulate Dr. Rishi. He did a fabulous job in a very difficult situation. And I think what he probably has learned is to be patient. And the patient has paid off to his patient. And I agree with everything he said today. These are very, very difficult cases, and you got to have a lot of patience because you'll be looking at this wound day in, day out, wanting to do something as surgeon, but you need to put your hands in your pocket and just shy away from doing too much. I think it's a great save for a young woman like this. You know, she may be left with a colostomy for the rest of life. So what? Life is saved. You know, colostomy doesn't really kill you, and then you can manage it. And she probably will be manage it for the rest of her life. But it is a great save. Thank you.
Thank you, Dr. Kasim. Dr. Frisbee, Atlanta.
Yeah, the only comment I have is I don't have any criticism concerning the loop colostomy versus double barrel. I know what the answer is. Everybody does, but you know, when you walk into the OR and you're looking at blood everywhere and open cavity wounds, it sometimes can make us take a step back. So you want to do the most important thing you can do as quick as you can do it. So I don't have any issue with the loop versus that. I know it's academically probably not inappropriate, but it could be done, you know, but I can understand the anxiety to want to do more. So at this point, you did a great job, Dr. Kim.
Thank you, Dr. Kasim. Dr. Antrach, Baghdad.
Yeah, so very, very well handled by Dr. Rishi and Dr. Kim. So very interesting case and expertly done. You know, about a lot of these things about the double barrel, the miculate colostomy, this is a lot of it is dogma, and people can take positions on either side based on certain studies. But you know, and all of this is pretty much dogma from the pre-evidence-based medicine era. So there've been actually no studies where you can compare them. But anyway, it worked in this case. Everything worked out fine. And about the feet, I thought that was quite interesting. I suppose you don't have any final X-rays whether there was complete union of the fractures, and then why the orthopedist just dealt with the sacrum and not the open fractures in the feet. That's a new one on me, but I guess your podiatry department's very advanced there, and they handle these things. But and then if you would, it'd be very interesting to get some later follow-up to see what happened, what the contrast studies look like, what the colorectal surgeons say, X-rays of the feet. I think we'd all be very interested to see how this case turns out. I'm guessing that that she won't need a colostomy for the rest of her life. The only issue is whether she'll need a colorectal reconstruction, you know, with a low anastomosis, or whether that's just going to heal like the rest of the pelvic wound. And so I'd be interested to see how that turns out.
Thank you, Dr. Antrach. Boston, Dr. Hochman.
I had to say that this was perfectly managed. Having said that, I have a complaint against Dr. Ratan. Why are not here more frequently? It's always great to have you around. So hopefully we'll see you more. But that's beside that, I think it was perfectly managed. And this is something that we always, some comment that we always have about this conference. And that's the reason I insist on my residents to participate in the conference, is that we show that there is more than one way to skin the cat. And this is having that mental flexibility as a trauma surgeon is critical. We cannot have one recipe to do everything. We see many times people doing the things a little bit different and having the same great results. And this is what this conference is all about. Have to keep us agile and our brains agile, and find different ways of solving the same problem, and see that make us all better surgeons. So thank you.
Thank you, Dr. Hochman. Dr. Martos, would you like to make any other comment?
Yes, I'd like to say thank you very much, everybody, for joining this meeting again. Dr. Ritchie, great case. Dr. King, excellent presentation, excellent management. I know the passion and the commitment that you have for your patients. And that's a great way to show everybody what you did for this patient, okay? Congratulations. And looking forward for more interesting cases that you're gonna have for sure during this second year of fellowship.
Thank you.
Okay. Thank you very much. If any of you guys are going to be at the WST meeting, please let me know. Maybe you can talk. Otherwise, we're going to all meet again next Monday at 8 a.m. Correct, Valeria?
Yes, and we have a doctor from Israel, Dr. Alan Schwartz.
I think the next Monday. Looking forward for a good case. Thank you all.
Great.
Thank you, everyone.
Take care.